Well, thank you all for joining this Royal College of Pathologists webinar. I'm Peter Johnston and I'm the Vice President of the college, and I'm responsible in the college for workforce and corporate engagement. And in my day job, I'm a consultant histopathologist in NHS Grampian, based in Aberdeen. I hope that you'll find what's coming up in the next hour useful, and so I think we'll just get started. You'll see from this slide that this is the third of three Royal College of Pathologists educational webinars that we've delivered in partnership with Roche Diagnostics. Roche have provided sponsorship funding for this activity, the purpose being educational and not promotional. I would make it clear that RCPath's involvement with Roche Diagnostics for these webinars does not imply college approval or endorsement of the company or any of its products. Having said that, we'd like as a college to note our thanks to Roche for their support and involvement, which has enabled us to deliver webinars such as this that we're doing today. From the next slide, you'll see that our speakers today are Professor Peter Sasieni and Athena Lamnisos. Professor Sasieni is the Professor of Cancer Epidemiology at the Wolfson Institute of Population Health at Queen Mary University of London and the Director of Cancer Research UK Cancer Prevention Trials Unit there. His research applies epidemiological methods to cancer screening, and he designs and runs clinical trials of early detection and prevention interventions. Athena Lamnisos is the Chief Executive of the Eve Appeal, which is a registered charity, and it focuses on the prevention and early detection of gynecological cancers. Athena has extensive experience in the UK and international patient participation and stakeholder engagement work around gynae cancers, specifically cervical cancer prevention. Following the talks, there will be a question and answer session. You'll notice from your screens that there is a Q&A box down on the bottom, just to the right of centre. Please post any of your questions you have in that box, and we'll try and cover as many of those as possible after the talk. We'll try and pool them together to enable a topic-based discussion and a conversation. You'll be able to view other people's questions and upvote any that you feel are particularly relevant to your interests. As I mentioned earlier, the college and Roche Diagnostics are collaborating on a series of webinars. These cover the three shifts in the government's 10-year health plan for NHS England, namely prevention, community and digital. The first webinar in the series, which we ran in September, was on enhancing patient care through AI-driven digital pathology. The second webinar was held in November, and it covered the shift to community, and it looked particularly at respiratory point-of-care testing. You can watch both of those on the college YouTube channel at any time. Following this series, we'll be co-producing a white paper on diagnostics as enablers in NHS England 10-year health plan, and this will be published in the summer of this year. So without further ado, would like to move on to the next part. If we can just ask Athena to present her slides now, we can move ahead.
Thank you. So look, delighted to be here and speaking to you all about kind of shifting the dial and what will change behaviour with all audiences to help them on the journey towards elimination. You probably all know a little bit about the Eve Appeal. We work across the 5 gynecological cancers. We're quite unique as a health charity and a cancer charity because we're prevention and early diagnosis focused. So screening is squarely in our sights. Early diagnosis, prevention of cancer, trying to stop it before it starts is where we put all of our effort. I just wanted to say a little bit about the policy backdrop because there's a lot of change and, you know all of this out there. There is so much change at the moment. We've got the 10-year plan and the 3 strategic shifts, and at the moment we're talking today about the shift to prevention. The National Cancer Plan was published a couple of weeks ago, and there's a lot in there about prevention and about the rare cancers, and it's important to note that cervical cancer is one of the rare cancers. 54% of cancer deaths are from rare, in inverted commas, cancers, i.e. not the big 4, and cervical is one of those. And we know that it disproportionately affects people affected by inequality and also younger people. So it's a really important one to address. So the cervical cancer elimination plans, really exciting to see them. The S is there for a reason. Each of the, devolution is a great thing, but it does mean that we have not just one cancer elimination plan. Each country of the UK has its own elimination plan, and they're all going at different paces, which doesn't always make things easy when you're communicating with audiences, because, we live in a global world when it comes to communications and how people absorb messages. And then we have the revised women's health strategy coming our way, and cervical elimination will be part of that as well. The Rare Cancers Bill should be law in the next few weeks, and that shines a light on a whole range of issues that, cervical cancer fits into. And I think running through everything, there's an increasing understanding of that focus on addressing inequalities and inequities, needing to run through everything. So reaching the right people and those who need us most, and those who are most left out of the conversation, and those being left out of screening, vaccination, and a whole range of other services. There are kind of a number of government plans and strategic priorities that I think I've touched on there, and just a few others to kind of mention. That kind of better access to information and research opportunities and digital opportunities runs through a number of different strands of NHS work at the moment, and will make a difference in this area and to your work about how we get results to people, how those results are explained to them, and those kind of better pathways of care, seeing elimination not as 3 different strands of activity and services. So vaccination, one chunk, screening, another chunk, follow-up after screening being the third, is really important. It's one pathway to elimination. And then really kind of listening to patients, listening to women, that's something that comes through certainly the women's health strategy, but also kind of every strand of activity. I've tried to incorporate into this presentation a kind of understanding from our perspective of what we've seen through data that we've collected. And we've done a number of YouGov surveys over the last couple of years that have given us a really rich insight into what the public and what patients see and understand by screening. And it's pretty worrying in lots of ways, the lack of information that there is. So 58% wrongly thinking that cervical screening is a test to detect cancer, 32% happily, correctly thinking and understanding that the test is to prevent cancer from developing and knowing what it is. And then this stubborn quarter who believe that the cervical screening test is something about all of the gynecological cancers, which is a really persistent quarter of people who probably do have quite a lot of health efficacy. They're going for cervical screening. They're not really understanding what it's there to do. And then they are really horror-struck and dismayed by, then being diagnosed, for example, with womb cancer when they've been attending their regular cervical screening. The vaccination backdrop is also really, really difficult in terms of what people understand by HPV and what they know about the HPV program. If we could really increase people's understanding of HPV and what it is as a virus, that would really help. 2 in 5 people not knowing that they were eligible for the HPV vaccine, 2 in 5 people unaware, only being aware of the HPV vaccine being for girls, not being not understanding that it's there for boys as well. HPV has no gender. it's a pesky old virus and it affects us all. And then really not understanding the HPV vaccine catch-up program. If ever doing media work, I talk about there being an HPV catch-up program for under 25s. We get a whole range of questions coming in to our Ask Eve Nurse Information Service. So, isn't it fantastic? Cervical cancer elimination by 2040 as a target and within our reach, within our sights. And we won't do that without full collaboration across sectors, industry, the third sector, charitable sector, and of course the NHS to deliver that. But what is the kind of magic ingredient that will help us meet that ambition? And it's not like food colouring into water that we can do one thing, change one thing, and suddenly, we'll reach elimination. There's a whole range of things that might need to change. But could the answer be Harry Styles? I mean, he's the answer to many things, but could he be the answer partially to meeting our elimination goals and increasing screening uptake? I don't know how many of you saw this this social media post that was put out by the NHS just before Cervical Prevention Week in January. It had a huge amount of traction and was a real moment on social media and reached a lot of people who might have previously not been listening around cervical screening messages. Why did it reach, those people? It got to the right people at the right time, really, culturally on point, accurate and on message. The caption was fantastically accurate about booking your cervical screening appointment, knowing that it was coming up if you were at that age. Tapping into, how old you had been when you saw Harry audition for X Factor, and that you're coming up to 25 now, which is the age at which, I don't know how many of you booked your tickets, but he's going on tour this summer. I've got my ticket. Coming from a trusted source, this information coming from a trusted source, the NHS, just brilliant and reaching the right people. However, is he the answer for everyone? And clearly the answer is no. He's not the answer to everyone for all sorts of reasons. There are so many different barriers to screening and why people aren't booking appointments and why people might find it challenging. Telling them it's a really quick test, it really isn't enough. There might be worries about pain, practical barriers about booking an appointment, language literacy, and specifically health literacy barriers, cultural, religious concerns, physical accessibility. That's one that comes up again and again. And past trauma. If you've experienced sexual violence or sexual trauma, there are all sorts of reasons why you might not be finding, booking a screening appointment easy for you. There are also misconceptions about screening, whether it's relevant for you due to age, due to your sexual history. So many myths abound. Fear of results and anxiety about having a test which is something to do with cancer, and the belief that if you look for it, you might find it. There's so much explaining that we need to do. And then, of course, the one that's often talked about, embarrassment and anxiety, which definitely does come into it with a gynecological test that's seen as an intimate test. But, there are lots of reasons for self-consciousness. And then system barriers. For example, if you're a trans or non-binary patient, you might feel that you face, other barriers, discrimination. You might suffer from body dysmorphia and a great deal of dissonance with parts of your body that might need to be looked at. But there are solutions, and what we see when we put out communications and proactively communicate on the issue is there are so many practical solutions. So whether it's flexible scheduling of appointments to drop-in clinics, offering reasonable adjustments and service choice options. So there's a lot that's talked about around self-testing, but that really isn't an obvious choice for some audiences, and the underscreened and never screened being offered that as an option is something which we're really keen to see rolled out. Community engagement and really building relationships across community groups, but with employers. We find our workplace programme is a really good place for people to ask questions about screening, and particularly where there are parents and carers in the room, a really good place for them to ask questions about vaccination. Partnerships working and collaboration is really important. And then the other thing that we find is really, really key is making sure that the whole screening workforce, and that includes everyone in primary care, those who answer the telephone to people looking at booking appointments and have got questions about what will be available to them, whether they can have a bit more time, is really, really vital. Awareness campaigns play a role, and what we found has really worked is communicating with patients about what the sort of top tips are for what they can do to make an appointment easier for them. And they're really simple things that people wouldn't have thought about until you've told them to, think about what they're wearing to a screening appointment to make them, feel more comfortable. Believe me, wearing a skirt, that's easy to pull up or pull off and not going in a zip up the front jumpsuit is a really easy tip to give someone and can lead to a very uncomfortable appointment becoming a very comfortable one. Social media is really very important, hosting activity and hosting messages that are easy to understand and really accessible. And remembering that the kind of social media in the online world is changing at a really fast rate. Google AI summaries are really taking over for a lot of people. They're not naturally visiting websites or trusted sources of information that they might have visited. They're relying on AI summaries. So making sure that you're reaching people with your social media, your messages in ways that they understand is really, really vital. And then, of course, monitoring and evaluating what is working and doing more of that, making sure that you're reaching the right target audiences, because this isn't about meeting everybody with a one-size-fits-all message. This is making sure that we've all thought about the precise audiences who are being missed out of the conversation so often. And then what else will make a difference? I mean, these are just a slew of quite big thoughts, but ones which we're thinking about and working with the whole range of stakeholders and policymakers and industry partners on. Well-funded elimination plans, including equity targets focused on reducing cancer and pre-cancer rates in underscreened and never screened groups. The provision of comprehensive and evidence-based information in inclusive formats and in trauma-informed, culturally and gender-sensitive ways. Close working with the National Screening Committee and a whole range of other NHS partners on the rollout of HPV self-testing across all nations. The development of shareable tools. Let's not invent the wheel on these things. There are a number of shareable tools out there, and encouraging everyone to work closely with the voluntary sector and the charitable sector to make sure that advocates and patients are part of this mix. What else will make the difference? Well, the invitation results system and taking a digital first results will be really advantageous for a lot of audiences. It's also remembering that digital doesn't meet everybody, and digital inclusion, has really got to be considered across a whole range of accessible formats as well. The expansion of screening accessibility with accessible options and flexible choice options about services, when to book, when you can book, as well as HPV self-testing is really vital. Joint campaigning for early and comprehensive HPV and cervical cancer prevention education in schools at an earlier age than the vaccine is offered, so that parents and carers understand why vaccination is important, why screening is important, well before that actually hits them and those invitations come through the post or those consent letters need to be signed. And so ensuring that that NHS England and all the national health bodies collect and share the data about who isn't and who is, accessing screening and vaccination. And then there's something that isn't quite working around all of the financial incentives around primary care, but ensuring that they prioritise and work for getting the underscreened and reaching the underscreened through their work is really vital. How will we know it's all working? Well, that's the key, isn't it? The key question is delivery. Are we seeing fast progress on increasing across vaccination and screening uptake as well as follow-up? Ensuring that the NCP set out screening is an important part of increasing cancer diagnosis. Collaboration between public and private players in the wider health ecosystem to accelerate and improve outcomes, seeing progress on waiting times. We know across gynecological pathways, waiting times. I mean, there are currently 750,000 women waiting in one gynecological waiting time or another. Some of those will be impacted by screening follow-up, etc. And then that pivotal role in improving diagnostics. You know, at the moment in histopathology tests, it is currently around 68% within 10 days, and the target's 98%. So kind of all to play for there, and so many different things playing in there. The key thing is they coming back to the inequalities, closing the gap with identified audiences and underscreened groups, and reducing those inequalities and the kind of postcode lottery that we see. I was going to leave you with some final thoughts and questions for you, really, that are probably coming, I hope, through the chat. What are the key things that we can change that will impact on increasing screening of those who we most need to reach and are most at risk? How do we communicate the changes in the programme, and who do we tell first to increase public confidence and understanding? You know, there are a whole number of changes and more changes to come. So whether that's around interval changes, or whether it's around self-sampling and who that's for and who we're rolling out to, and which groups will benefit most from self-sampling implementation. We know how that's being rolled out, but being really prioritised about how that's done. This is a social media. This is a social media post that we did last year, which gained a lot of traction and led to a huge spike in calls to our nurse information service. And it was literally just making people aware of the kinds of things that they could ask for and that would really help motivate them to book their appointment. We also did a social media and outdoor media campaign, which looked at sort of top tips and was kind of provocative in the way that it approached the issue. It was making a play on all the things that you could ask for that, you know, might be interpreted as double entendres. So, you know, you could switch position to make screening more comfortable. Size matters. You can ask for a smaller speculum. You know, you could ask for more lube to make it more comfortable, and that provoked a conversation which was really valuable with a range of younger audiences. I think this barcode will be circulated to you afterwards as well, but do come to us for any further information if that might be helpful to you, because where we all want is, you know, to reach our vision where gynecological cancers are prevented at an earlier stage. That's what we want to do, and we can only do that together.
Athena, thank you very much indeed. I really like the way you contextualize what the role of pathology is to give us that wider look at it all. And I think that's very helpful. And I was also, I thought that the real world approach is so important around these things. No woolly language about this is the way it is. I think that's really important, getting these messages across. So thank you very much for that. I now, we just don't know what's happened to my video. There we are. We'd now just like to invite Peter Sasieni. I'm glad to see you back with us, Peter. Your IT sorted. If you would like to carry on with your presentation, now we'll have time for some questions at the end.
So thank you very much for inviting me, and apologies, my internet went down.
That's good.
So a conflict of interest that I have a patent pending on the use of CT values for triage of cervical vaginal samples. So I wanted to give a very brief history of cervical screening first. So going right back to 1942, when Papanicolaou and Trout published describing the cervical smear, cervical cytology. And one important issue there, which I've illustrated with these different types of spatulas and brushes, is that if you're going to do cytology, you really need to collect a sample from the whole of the transformation zone. And so what sampling devices you were using and how you trained staff to collect smears was really, really important. But then with the discovery that HPV was the cause of squamous cell carcinoma of the cervix, so I think 1995 is the Wallboomer's paper that showed that all but 3 of around 1,000 cervical cancers had HPV DNA in them. And so in 2002, we proposed exactly how you might use HPV testing to transform the cervical screening program and have using HPV testing instead of cytology. And because HPV is present all over the transformation zone, and in fact in the vagina too, you don't need to collect such a good sample. And so taking a line from testing for sexually transmitted diseases, we thought, well, maybe you can use self-sampling. And so there were various papers, first of all, proposing that self-sampling could be used, seeing that it would be a more attractive option to a lot of people who were not participating in screening and to different ethnic groups, and then looking at the accuracy of HPV testing from a self-sample to compared to on a clinician sample, and then culminating with the recommendations that this should be used within the screening program last year and the starting of that this year. So cervical screening works. We estimated that regular screening with cytology prevents about 85% of cervical cancer mortality, slightly less of cervical cancer incidence, because although generally we find pre-cancer and treat that to prevent cancer, sometimes cervical screening finds a very early cancer. And so you haven't prevented cancer, but you've prevented the woman dying from cervical cancer. Women born before September 1990 in this country are not going to be protected by HPV vaccination. So screening is still essential for cervical cancer control. But unfortunately, cervical screening coverage is falling. It was close to 80%, over 80% years ago. In 2024 in England, the coverage was 69%. In London, it was only 61% and actually lower. And Athena just pointed out to me that Scotland's just published new figures showing that it's actually only 55% last year in Scotland. So cervical screening, we have a problem with screening women. Just to reiterate that HPV testing is better than cytology for primary screening. It's more sensitive for detecting high-grade CIN. The duration of low-risk following a negative screen is much longer, which means you can have longer screening intervals. And randomized controlled trials shows that you can actually prevent more cancers. Not all commercially available HPV tests are approved for use within the NHS cervical screening program, and even fewer are approved for self-sampling. So this slide, I want to sort of summarize what is really known about self-sampling and cervical screening. So there's a matrix here. The columns looking at test performance and increasing participation, and the rows looking at the underscreened and in routine screening. So meta-analysis in underscreened shows that the test performance is really good. So the point estimate is point in a relative sensitivity compared to using a clinician sample of 0.99 with very narrow confidence intervals. But far fewer studies have looked at self-sampling in routine screening using routine labs rather than research labs, where the sample collection is often unsupervised, as many of those research studies. There was a nurse standing in the background if the woman had questions about how to do it that could be answered. And actually thinking about how long it takes to transport the sample from the home or wherever the woman takes it into the general clinic. And suggestions from the Netherlands that actually the sensitivity is slightly less good. And that's important because if it's slightly less good and all we're doing is transferring who gets tested, we might be having less impact on cervical cancer incidence and mortality in the population. And we now have 4 different combinations of assays and transport conditions and sampling devices that are approved for use for self-sampling within the NHS or from NHS. In terms of increasing participation, it's clear that it's not simple, that this is a magic bullet and all you have to do is say, oh, we've got self-sampling, everyone's going to do it. If you just send somebody a letter saying, would you like to have self-sampling, in the meta-analysis, only about 4% of those people will respond positively. If you send them a kit in the post, about 13% will send back a sample. But if you offer self-sampling in person in a healthcare setting, about 28% responded. And if you really do community outreach, you can get close to 40% uptake. So how you offer self-sampling is really important, and it's something that we're going to have to get right within the screening programs in the UK in order to make sure that we really can improve coverage. In the Netherlands, self-sampling was introduced in 2017. Many women use self-collection, but screening coverage hasn't increased. Of course, it's difficult to say. Maybe it would have fallen substantially had they not had self-sampling, but nevertheless it hasn't worked. And a similar picture in Australia, where self-sampling was introduced in 2022. A lot of women are using self-sampling, but it's not clear that coverage is increasing as a result. So we did 2 studies, which I want to talk about briefly. The Aloha study was in West London, and it was a factorial design. So we randomized GP practices. It was only a small study. It's 13 practices to either offering self-sampling opportunistically when women came to the GP or a nurse. And that was one randomization. And the other was when women were exactly 15 months overdue screening, or women who had never been screened before and were overdue screening. They were randomized into 3 groups. Some of them, there was nothing done. Some were sent a letter, and some were sent a kit in the post. And you can see here that amongst the women who were in GP practices, that there was no opportunistic intervention, and they were randomized to have nothing. 17% of them were screened over the duration of the study, compared to 31% of those who were sent a kit and came from a GP practice that was offering opportunistic screening. So if you use the right approaches, you really can have a substantial impact on the proportion of women who are screened. And so here it would look like the opportunistic offer only added 5%, whereas sending out kits, we could increase the uptake by about 10%. But if you look at uptake rather than coverage, you see something quite different. Sending out letters is really very inefficient. Only 1 in 20 people who we sent a letter to returned a self-sample. Sending out a kit is a bit better. So 12% of those who were sent a kit returned a sample. But if you actually offer a woman a kit in general practice, 55% of those who were offered a kit returned it. So the challenge is, how do we get more women to be offered a kit when they're overdue screening and when they're consulting with a GP? Because we know that in the majority of those consultations, despite the fact that the study was going on, an offer wasn't made. And that could be because the woman was not in a fit state to discuss cervical screening with, or it could be that the GP knew that there was a huge waiting room full of people and didn't want to delay that longer. But when the nurse or the GP made that offer, in over 50% of the cases, it was taken up. And then NewScreen really built on Aloha, and so the aim was to test the end-to-end pathways for introducing self-sampling to non-attenders within the screening program in the NHS, and to see to what extent it could improve coverage. And it was the first time that a negative self-sample counted as a negative screen in the UK. And that was really important because we'd seen previously that both clinicians found it very confusing that they'd get women to be screened and then it didn't count to their screening coverage. And women would have a negative self-sampling within a study, and then they'd contact us 9 months later to say, but I don't understand it because I've just had this letter to say, you're now 6 years overdue screening, you really must come, and what's going on. So it was important that those results could actually change things. And we sent out kits which had information and return envelopes. And again, it was the 2 parts, a systematic offer 15 months after the test was due, which we did a pre-notification letter followed by a kit 7 days later, and an opportunistic offer to anyone who was at least 6 months overdue in general practice. And again, we used a flag on the GP system. So if anyone opened the records of a woman who was overdue screening and eligible, then the flag would come up to tell them about it. And we randomized when GP practices would start participating in this, so we could see it was a wave to see what the impact of these interventions were. And you can see that in terms of uptake, so we looked at it in 3 ways. Uptake, 11% of those who were sent a kit in the post returned a sample, compared to 55% of those who had an opportunistic offer. In terms of the impact on coverage, well, in the GP practices that were not participating, which was 62 of them, was a slight fall in coverage. And in the participating practices, there was an increase in coverage. So overall, this study that ran for the intervention was done for 7.5 months. It seems to have increased coverage by 1.6%. So if that was extrapolated to what might happen over a 3-year screening cycle, and of course now the screening cycles are 5 years, that would be 7.4% absolute increase in the coverage. And in terms of the numbers screened when they were overdue, we found that there was a 22% increase in the number of women who were overdue screening who were screened in a month where the full intervention was happening. So these 3 different measures all suggesting that really this can work, and you do need the combination of approaches to get the best impact. It's also really good to see that there was quite inclusivity in terms of those who took part in screening when it was offered in this way. So on the left, you can see that over half of the women who returned a sample were at least 2 years overdue screening. So this wasn't just, there's been some delay and we got them at just 6 months overdue screening, and they probably would have come in any case. Half the ones had with over a quarter of them, in fact, having never been screened before. And then in terms of who they were, 29% were Asian, 10% Black, 18% from mixed ethnic groups. So 63% came from ethnic minorities. And the non-attended population is generally more deprived. But you can see those that responded, those that returned a sample, had pretty much identical distribution in terms of deprivation as the target population as a whole. So we received 8,000 some self-samples back. 13% of them were positive for HPV. If they were, we asked those women to come to the GP for a clinician sample. 89% of them did. Because of that, 3.3% attended colposcopy, and in 1% of the 8,300, high-grade CIN was found and treated. And there are another 2% who were put on 12-month recall, and we don't have the results for those. Participant feedback was really good, both from the women and from the primary care team. So one woman wrote, "Thank you so much for running this study and this method of sample collection. You've taken a genuine weight off my shoulders." And one GP wrote, "I've had sexually abused patient, a woman with FGM, and a chaotic and vulnerable alcoholic who had always refused face-to-face smears, who were happy to have self-screen, 2 of which turned out to be HPV positive." So really popular approach amongst both the public and clinicians. But one of the problems with self-sampling is that it's really good for collecting a sample if there's HPV present, but it's terrible for cytology. You cannot hope to do a triage with cytology, which means that women who are positive on a self-sample need to go to the GP for a regular screen, if you like. So we wanted to see, can we use something in that self-sample to do the triage? And so we use something called CT value, which is a rough measure of the viral load. And we were using the Roche Kobash test, and so we had information about whether it was HPV 16, HPV 18, or other high-risk HPV types, and we had these CT values. So in 855 women, they were HPV positive, they'd had a clinician sample, and we knew the CT values. And 49% of them were HPV positive on the clinician sample, 29% were referred to colposcopy, and 8% of them had high-grade CIN. And you can see here that the CT values on the self-sample were indeed much higher in the women who HPV was negative on the clinician sample, and it was lowest in those who had abnormal cytology. And the relation with the CT value for HPV 16 is even stronger. You can see there's a very strong link between the probability of having high-grade CIN found and the CT value. So based on that, we divided women into 3 risk groups. So of 855 women, 44 were put in a high-risk group. 82% of those would have been referred to colposcopy, and 43% of them had high-grade CIN. So we would suggest that anyone who falls in that high-risk group can go straight to colposcopy. They don't need to go to the GP for a smear. And just over half were put in the low-risk group. Only 4% of those women had high-grade CIN, and only 2% had CIN3 or worse. And so the middle group, who now is less than half of the women originally, we would suggest need to go to the GP for a clinician collection sample. But that low-risk group, just over half the women, could have a repeat self-sample in 12 months because their risk is very much like the risk in a woman who is HPV positive but cytology normal in the regular screening program. We did health economic analysis together with a group in Australia, and doing the opportunistic offer only would prevent about 3% of cervical cancers, and at a very cost-effective at about just over £2,000 per quali. The conclusions of the health economics is that offering self-sampling to underscreened women as part of the national screening program, particularly when offered in a GP setting, is both cost-effective and is likely to reduce health inequalities. And as a result, self-sampling is now available for underscreened women within the cervical screening program. And I'd just like to acknowledge lots of people who've helped with this, in particular Anita Lim, who was my colleague quite centrally. Thank you.
Peter, thank you very much indeed for that fantastic tour of the literature around this interesting topic. While you get your breath back, I've got a question which is prompted by the anecdote that's on the Q&A for Athena, which, I mean, it's all about information and getting the right information out there. I mean, why do you think that people don't really understand what the role of cervical screening is and what it's for and what it's not for?
I think there is such a kind of variety of reasons. The whole kind of way that we consume health information has changed, and we have a lot of passive consumption of health information from, frankly, untrusted sources on social media. We also excuse me, we also don't have we aren't starting early enough with health education, and we really do need to look at the sex education curriculum, and which we've got to remember what the H is for in PHSE, and really get those messages right. And we don't take every opportunity to educate that we can. So, it's about having those kind of significant moments and conversations with trusted people. So we've got to think about opportunities in the workplace for lunch and learns around health issues, etc., etc. So there's a whole range of issues, but there are answers to all of them.
Thanks very much. I think that's a message to all of us, really, as healthcare professionals. It's all of our responsibility to make sure that we get that message out, isn't it? So, good. There's quite a number of questions about self-sampling, Peter. Adequacy, what are we doing about programs around about it? So adequacy, first of all, it's an issue with conventional means of cervical tests.
So if you collect the sample, and particularly if you believe in transporting it dry, the adequacy of the sample is really very good. And a lot of women have concerns they don't take the sample correctly, but that is very rare. Mostly it's when it's blatantly obvious that they haven't collected it properly. If they took a nasal sample, that's not what they were meant to do. And so it's difficult to rule out, even if you're testing for human DNA, that the sample's taken from the right place. But it's a pretty good sample. For certain things, it's not as good. So if you want to do certain DNA methylation tests, there's less material there. It may not work in triage as well. But pretty much it's a very good sample. There's interest, I saw something in the questions, but there's interest in urine samples, which are almost as good, but not quite as good as vaginal swabs. And then using sanitary pads or tampons, which create a lot of complications. And unless it was shown that they really made a huge difference to the uptake, I would not suggest people do it. The work in the lab to do the test is hugely greater. You've got to worry about what contaminants there might be. And so even if you do one study, so we could do this really well, it's like, well, it's not really scalable. And I would be quite worried about trying to do that.
Yeah. Okay, that's interesting, because there was a paper in the BMJ about that recently, wasn't there? And so we would just go on and ask about the uptake, really, of screening, and issues around whether people are delaying taking up screening, waiting for the implementation of self-testing to be rolled out fully. My understanding is that has happened, but I'm not sure exactly where we are with that. But what are your views on that and the guidelines around how we persuade people, and how that affects waiting times and uptake?
I mean, I don't know for sure of anyone who has delayed, not had a test because they think, oh, self-sampling will come on soon. So if I wait 6 months, I can get a self-sample. It would be a very dangerous thing to do at the moment, because it's not clear to me that self-sampling will be available to most women who are 6 months overdue screening. So exactly how it's being rolled out, so the National Screening Committee have given it the green light, but it's up to local areas to decide how they want to do it. And they may not do anything, certainly not immediately. So there is some work going on, but there are all these questions. If it is slightly inferior, should we give women the choice? You know, if they say, well, I'd much rather do this, I don't care if it's, you know, a tiny bit less good, it's so much more convenient for me, I'd rather do that. Should that be part of a proper choice? Does giving people a choice actually make more people want to take part? Or do people get confused by a choice and think, oh, I don't know, if they don't even know which way I should be screened, it can't be that good, I'm not going to do it. I think, you know, more because screening coverage has been falling so rapidly since COVID, that we do need to do more work. It's clearly a complex issue, and a lot of it is that women are not getting around to screening, so it's not prioritized highly, and it's not easy to do. Mm-hmm. So that I think the number who are making an active decision not to be screened is quite small from the research that I've seen. Yeah, not exactly my area. I don't know if Athena has.
Yeah. Have you got anything you'd like to add to that, Athena?
Just to add that a lot of careful and clear communications is required. So, you know, things like interval change, you know, whether people are waiting or not or confused by that. Or, for example, we're going to be communicating that self-sampling is being rolled out to underscreened, never screened, those who have delayed screening. Whether people, the wrong people, if you want to call them the wrong people, will actively decide to delay screening to have the opportunity for self-sampling. Putting out messages around that are very good news and are absolutely based in evidence. So in a vaccinated population, no reported cases of cervical cancer in Scotland, for example. That's a really good news story. Is correct. However, if you don't understand how HPV works and how cervical cancer develops and how long it takes, you understand that in the wrong way. So making sure that we get all of these communications absolutely right. You can't communicate enough on this, and that it has to be cross-sector and collaborative so that we are all saying evidence-based things is very important. But where Peter's right is we don't quite know what the reasons are, but we know they are different reasons for different audiences, that they're not accessing screening when they should be.
Mm-hmm. That's really interesting, isn't it? That we need to try and tease that out. There's another aspect that's been brought up by one of the questions, which is around it's the HP validate, which is around further studies and workflows, and particularly with relation to home samples. And there's questions about what I guess is around MHRA and the part of allowing these you know, to the validation of these kits. Do we have a concern about the accessibility then and of what is available and its usefulness in the clinical setting? Peter, do you want that one?
Well, I think, you know, we do need to think about, you know, where kits are going to be stored and how they're distributed. So if you look at bowel screening, you know, GPs don't have a stash of kits for screening, so they can use fit testing in symptomatic individuals. But if you want to do screening, because they want everything pre-labeled so that there isn't this complexity of the labeling of the test sample not being done properly, they're all sent out centrally. So screening is this mass production, and we do need to think about the details of how you make sure. I didn't talk about it, but some of the samples we received back in Uscreen, we didn't know who they came from, and there are issues of, you know, because the labeling wasn't quite right. So having to think about all those details if you want to try and get it on a mass scale. But I do think, you know, we could be doing a lot more in terms of self-sampling. But as you kind of were saying in your previous question, what you will want to make sure is that it doesn't backfire and you don't end up having even fewer women participating in screening because they're going, oh, well, I'll wait until my self-sample kit comes, and then it never does.
Yeah, and similarly, you don't want to have the opposite effect of having a lump of cases that are a lump of screening that comes unnecessarily, as we've had in the past, the so-called Jade Goody effect from 20 odd years ago, which really almost floored pathology departments when we were still doing everything manually. I think the there's a few other questions coming, and some of them are about more about the science around typing and what we should be reporting in terms of the screening test. So one's about false negatives. We talked about adequacy, but how do we handle false negatives? Because if the cervix isn't visualized, it's probably more difficult to be sure that we are getting a good sample. And then moving on from that, what about typing and the relationship of what we're seeing to the risk? There was a slide you had about that, I think, earlier, Peter.
So I don't think it's a major worry about the false negatives. HPV testing is extremely good, and self-samples, vaginal samples, are a pretty good sample to do that with. I would be more worried with sanitary pads or even urine. There is a question, of whether we should have an occasional clinical sample, because from the very small proportion of women who just do not understand the instructions, however simply and clear we try and make them, and collect a sample from the wrong part of the body. But I think that's probably pretty safe. In terms of the typing, in the UK as a whole, I think because of the quality of cytology, we've decided that typing isn't essential for triage, whereas many other countries do HPV typing so that HPV 16 and 18 go straight to colposcopy rather than using cytology triage. But I think because you can't do cytology triage on a self-sample, I think it does make a huge amount of sense to be thinking about it, because the risk associated with 16 in particular is so much higher than other types. We also have to think about what's happening with HPV vaccination. And so exactly how cervical screening should change, I mean, I think it is really important, and there probably are mixed messages, because women hear that, oh, vaccination's amazing, I've been vaccinated, and yet they're being told you must come for screening. And so there clearly isn't something quite right in that messaging. But also, if a woman has been vaccinated when she was 12 or 13, is HPV 16 positive, it's more likely that that's a false positive, in the sense that it's probably just a deposit rather than a true infection, rather than in someone else where it's quite likely to be and so if you were to repeat the testing, it's probably no longer there. So the significance of HPV positivity, and particularly HPV 16 positivity, might be quite different in a vaccinated woman than a non-vaccinated woman, and we haven't really come to terms with that. And that's why the role of cytology may become even more critical, because hopefully you can actually identify what is the true disease rather than
Okay, well, thank you very much. As ever, a good presentation leaves us with questions at the end rather than just simply answers, and thank you very much for that. I think it's probably time for us to wrap up, and so thank you all for joining us today. I hope you found it worthwhile. I certainly have, and it's made me reflect, if nothing else, on the fact that Betty McGregor, who really was responsible for starting a cervical screening in the UK, she worked here in Aberdeen and actually taught me my cervical cytology when I was in SHO a long time ago. And it's nice to see the science is still ongoing and that what was started is continuing. I would like to just remind everybody that the college does have a calendar of CPD events, and if you keep your eye on that, you'll see what is happening there. And there's a QR code at the top of this slide that's on now to allow you to see that. You'll also be getting a feedback form, so please fill that in because it helps us develop educational webinars as we go forward. The link to the recording of today's webinar will be available on the RCPath YouTube channel for those who've registered shortly, and you'll be able to see it there. Do have a read of the recent Power of Testing report, which was published in September last year and developed by Roche in partnership with IBMS and supported by the college. And again, the bottom QR code on the slide is the one that you can use to access that. So I'd like to thank our speakers, Athena, Lamnisos and Peter Sasieni, for their learned and interesting contributions, the skillful and interesting discussion that's followed, and thank you for your participation. Enjoy the rest of your day, and goodbye. Thank you very much.